Well, good morning, good afternoon, and even good evening to all of you who've joined us for the second half of today's session. I say that because we've got a global panel for you today, all different time zones, rubbing their eyes, either just woken up or just about to pop off to bed. My name's Andy Bleaton. I work for the ECH Alliance, the Global Health Connector, as the director for our communities. What we're planning to do today is a session which is building on what you've heard so far today about the European health data space and modernisation and digital health, but to take our value as the global health connector and think, why are we reinventing the wheel here? What can we learn from other continents and what can we share with other continents? So I'm really pleased that we'll be able to bring in best practice, knowledge and experience from Latin America, from Africa, also from Europe, from Portugal, and lastly from the USA. Always on our minds today because of the news. But I will give some fantastic examples there from the US. What we're going to try and do today is look at some of the opportunities that are there around sharing data. And also then hopefully to be able to say to you, here are some of the opportunities, here are some of the experts within our network, whether it's Felix from Tanzania, Mayer from Chile, Sarah from Portugal, or Betsy from Florida, or you can make a direct connection with through our ecosystem network, because that's what it's there for. This is an implementation network, and these are great examples of successful implementation. If, like me, you've heard quite enough about the European health data space for one day, hopefully we'll get some different examples from expertise in Portugal, who I think are one of the lead countries within Europe on this. Also, we're seeing fantastic innovation and growth, not just across Tanzania, but across a Pan-African network with Felix as well. And then last of all, we'll be coming to the US to see how One Florida have been approaching this area. But without further ado, I'm going to get on to our first speaker, Mayer, from our Chilean ecosystem, SENS, who's going to tell us how are things done there in terms of sharing data in Chile. Mayer, over to you.
Okay, thank you, Andy. First of all, I'm really thankful for being here. I'm going to go with a quick introduction. I'm part of the National Center for Health Innovation Systems, that's called SENS, which is also the organization that it's initiating the EcoSD, that's the first Chilean digital health innovation ecosystem. Together, EcoSD and SENS, we advocate to advance digital health transformation, but also data sharing as a means not only to provide a better healthcare to reduce patient journey fragmentation, but also as a means to enable better research and to boost innovation. We believe that access to localized quality health data is a must to develop effective technology and promote social well-being here in Chile. So while Chile has some experience with data sharing among different government institutions, we've only recently begun advancing in health data sharing and interoperability. For many years, here in Chile, that exchange has occurred in a centralized manner where all health providers are required by law to send aggregated or individualized databases directly via some dedicated platforms to a central national agency for processing. But this data is mostly used for statistical purposes and to enable central level decision making. Only some of this data is then released as open data sets for the general public to take advantage of. So there's currently little to no data sharing among health providers. And the most common use cases are only interconsultations among different levels of care within local referral networks or between referral centers where patients are referred to with some relevant clinical data, but that's it. Most patients will still need to physically provide access to their clinical history and exams. And probably the most advanced system we have right now is our National Immunization Registry, where information from all public vaccine administration centers and most private ones is held. Secondary use of data for research purposes, it's common within healthcare organizations and among university researchers, but access is given via each organization's individual criteria, and it's usually very cumbersome and usually doesn't require patient consent. But that said, since 2023, we're experiencing a large regulatory change, and we've passed several new laws that will enable us to better share data in the future. Just this last year, we had a new data protection law that's homologous to the GDPR, and it also creates a National Data Protection Agency and a new cybersecurity law that sets the minimum requirements for IT systems in this regard. And we also have passed a new interoperability law that requires electronic health records to be able to provide interoperability with other healthcare organizations, but it doesn't enforce it. So we're currently waiting for the rules for the law implementation, which we hope will enforce the use of international standards such as LOINC, SNOMED, CT, and FHIR, and also set the conditions under which data sharing will be mandatory. We're still doing advances in interoperability through our HL7 national chapter, but while we wait for the law to come in full force, we expect interoperability to enable data sharing by helping us make sense of all this data. This new data protection and cybersecurity law pose huge challenges for healthcare organizations here in Chile in order to safeguard policy, but also to responsibly share and make secondary use of data. It will force a cultural change and will also force the reskilling of the current workforce. And all these changes are yet to happen. We are certain that actors taking part of innovation ecosystems will be in a more advantageous position to take part on the upcoming data sharing within Chile.
That's fascinating. I think certainly for many of our audiences, this is going to be enlightening to see that you're going through similar issues, and it must be areas where certainly different countries and continents can learn from that, especially about the regulatory framework. So I think very, very interesting to see. I'd like to compare that now, contrast that, get on a plane and fly over to Tanzania and listen to Felix from our ecosystem soon to be announced and launched in Tanzania. Felix, tell us how things are similar and different there in Tanzania, in Africa.
Thank you very much, Andy, and good evening from this end. So as you can see from the screen, I work in Tanzania and a university within in Dar es Salaam, and I also lead an ecosystem, as indicated by Andy, on Digital Health and Innovation Alliance, where we also organize a platform where people can interoperate. So we talk of system interoperability, but we are more focusing on people's interoperability to ensure that they talk first and understand the data ecosystem, what can be shared, when, and how. So this is what we are doing. And this November, next week, we are going to have a Grand Digital Health Week. And 1 week, the one thing that we started yesterday was training on health data analytics, machine learning, where also health information sharing is part of the ecosystem. So I will start by presenting what we have as our health system. So I'm sharing my slide. So if you look at the topmost in my slide, the first picture shows our health system structure. So it's good to understand how the health system is organized so that you can also understand how you manage data and how you can share data. So there are two arms where you have the private health sector and public health sector, where we have about 60% of the facilities and ecosystem is within the public sector, and then the 40% within the private sector. And each of these are running several facilities in a pyramidical structure, as you can see, with the community level services, primary health care, regional level, and then you have the national and specialized facility. So this structure provides huge heterogeneous data in structured and non-structured. And this is more focusing on the routine data system because these are where services are delivered. But we also have other structures within the health sector and beyond that are collecting data. So that tells how we have the structure, and data flows from the community level to the facility level. We have on the bottom right, we have our health information exchange interoperability layer, a blueprint that shows how the systems are connected. So within the service domain, so we have systems that are mainstream in terms of electronic medical records at the facility level. Luckily, within the public sector, there's an agreement that at the primary healthcare level, you have an EMR that is used in almost a large proportion of health facilities. I think about 1/3, because some of the facilities are rural, but most of the facilities at the higher level, from the district to national level, they have EMRs. When they are centralized, it means data sharing is easier because you can then ensure continuity of care by tracking an individual. In terms of institutional frameworks and governance framework, we have the ministries responsible for health at the lower level, but also at the national level where they set policies. There is a blueprint, enterprise architecture blueprint that defines structures around data and other architectural framework. As I've said, the mediator is there at both national and lower level, but the government has also a government enterprise service bus to ensure the systems are exchanging what we need at different levels. We still have some challenges between the public and private sector because the systems need to be harmonized, ensuring the standards. So the standards are defined, but implementing them needs skill sets, needs infrastructure to be in place, and ensuring that the governance systems are in place. So the other aspects that we have in place in terms of the governance frameworks and institutional framework, we have now Personal Data Protection Act that promotes data sharing, but in a ethical manner. But we also have the institutional framework like Commission responsible for data protection. But the ministries of health, they also have sector-specific guidelines that promote standards in terms of aggregate level data. That's where we are doing very much well in terms of making sure the routine service data in an aggregated manner are available at different levels for decision making. But at the individual level, we are also, as we said, centralizing system to ensure that the systems can share within the public health sector, but also beyond. And now this is happening because we are developing a unified identification system that is hindering personal level, individual level data. And hoping this is going to be, towards the end of this year, the identifier will be available for everyone to ensure that individual level can be shared across the entire health system, but also for other health social services. Thank you very much.
Well, there you go. Much more information than even I knew about Felix's background, and I think a really good example of where we need to pay attention and look outside the window a bit more from your own country and think, well, what do other continents do? Because that's important. That's the whole role of the Global Health Connector, to bring that global view. So we've been to Latin America, we've been to Chile, we've been to Africa and Tanzania. Let's come back into what I think is one of the areas of expertise, and I can say that because no one can stop me. But one of those areas of expertise in Portugal, within Europe. Sarah, please, the floor is yours.
Thank you. First of all, thank you for inviting Health Cluster Portugal and having me in this session. So I would like to start this presentation to provide a brief summary of the Portuguese health system. So Portugal provides a growing example of implementing electronic medical records and implementing admission and discharge systems, and Portugal also has a national electronic prescription and dispensation system across both public and private sectors. So this landscape of very digital digital and innovation systems enables both primary and secondary use of health data in Portugal. In terms of primary data use, the country is well positioned in Europe, and namely the Portuguese citizens have access to their health data generated in public, social and private healthcare service through different electronic portals. A complete digital register of Portuguese citizens can be accessed by healthcare providers inside the National Health Systems network with different data types. So if healthcare providers can access the data of their patients, they have more possibility to provide better healthcare service and better diagnostics, treatments, and clinical findings better tailored to the patient's conditions and patient's needs. Also, as I referred, Portugal has a national electronic prescription that connects hospitals, care centers, and community pharmacies. And in terms of data sharing across borders with other European countries, Portugal already participates in the My Health at You infrastructures, and it is an infrastructure related with the European Health Data Space. And I think in this session we will have opportunity to explore better the European Health Data Space. But briefly, My Health at You is the European infrastructure that enables data sharing among European countries for primary use activities. So at this moment, Portugal participates in these infrastructures by sharing the patient summary and electronic prescription and dispensing of their citizens. In terms of secondary data use, Portugal is less advanced, but I think it is a most common scenario, at least in Europe. So Portugal follows the GDPR, the General Data Protection Regulation, that regulation the protection of natural persons concerning the processing of personal data and the free movement of such data. For a Portuguese institution that intends to use data for secondary activities, namely for research activity, the institution needs to follow the GDPR, and for it, the data protection officer of this institution should act as a data control to analyze the compliance between the intended data use and the GDPR requirements and conditions. Normally, this evaluation process of compliance is easy or simple, but where it is intended to produce new technology or use a large scale of data, there is a need to conduct a data protection impact assessment. And it is important to evaluate the context of processing data and its use. These impact assessments includes first an analysis of compliance with the fundamental GDPR principles, the need of processing and how the data subject rights are protected and ensured. Then an assessment of the re-identification risk, and in this phase includes an analysis of a probability of the patient be re-identified with the data used, and then a formal validation is made, and it is decided if the data can be used or not can be used for this specific research activity. So this figure that I am sharing illustrates this legal framework for research activities, and I think it is important to note that currently in Portugal there is no a national data lake or a national infrastructure that collects data for secondary activities. There is some local institutions and regional institutions that promotes data for secondary activities, but there is no a national framework. And in this moment, Portugal is working on developing a national technology platform for secondary data use, and the Cluster is involved in this work, and also to be included in the European data space for secondary use. Thank you.
Wow, fascinating, full of facts. I think a really great model there about the use of research data. So I think some of our colleagues will be taking note of that and coming back to you, Sarah. I can't believe you kept it such to time. I don't think even there was a second spare, so well done, and well done for getting all that information across. Very clear why we wanted to come to Portugal, because they're, I think, certainly from our ecosystems, one of those leading countries to watch within Europe. Now then, we've had that input from Africa. from Portugal, from Tanzania in Africa, Portugal in Europe, and obviously in Chile. Now then, I want to come to the USA. Why? Because we've been regularly keeping an eye on what's been going on in the US around health data sharing. And what better example I can't think of than we're going to hear now from Betsy from One Florida. Betsy, tell us what goes on.
Andy, thank you so much. So I want to talk a little bit about the One Florida Plus Clinical Research Network. And just as way of background, One Florida Plus is part of a nationwide network that comprises 8 such clinical research networks across the United States, comprised of health systems and health settings that provide care for over 80 million individuals in the U.S. The portion that I will talk about today is One Florida Plus, and this map shows our partners throughout the state of Florida, which is the 3rd largest state in the United States. And we also have added additional states from the U.S., including Alabama, Georgia, Arkansas, California, and Minnesota. And a very unique component of One Florida is the fact that we have what we call a centralized data trust that contains electronic health record information from 2012 to the present. It's refreshed every quarter, and it comprises almost 28 million patients. We link these patients and deduplicate them, and I'll talk about that in just a minute. The other thing I also want to stress is that the variety of settings throughout the state of Florida, as well as the other states that are participating, provides enormous racial, ethnic, and geographic diversity, as well as age and socioeconomic status. So this is a model showing you the One Florida Data Trust. We harmonize the data from multiple electronic health record platforms into a common data model that is defined by the funder, which is the Patient-Centered Outcomes Research Institute. So that is a funding agency that was developed under the Obama administration with the goal of conducting patient-centered real-world research. And so the data are harmonized from multiple platforms, and we ingest it into the data trust. We use a privacy-preserving software to link the electronic health record information to birth and death certificate data in the state of Florida. We link it to patient-recorded outcome information. In the United States, we use zip codes, which reflect census tract information, and so everybody is geocoded to their census tract. So we have information about their environment where they're living. We also connect it to environmental data, air quality, so that's very important. We also have what we call in the United States healthcare claims data that are records of where people got their care, regardless of where it was in Florida. It can be at a healthcare system that is not part of One Florida. So we also use a privacy-preserving software to link the data to healthcare claims data from public insurance entities like Medicare for older adults and Medicaid for lower income women, children, and some male adults. It is also linked using this privacy-preserving software to national death data. And then we also have developed natural language processing pipelines where we extract clinical note data from the electronic health records about things like adverse events for healthcare. We also extract information about the social circumstances such as occupation and other information, and we extract it from the note data, and have we created an NLP pipeline to feed it into the data trust. In addition, this privacy-preserving software deduplicates the patients across the other clinical research networks, as well as within One Florida. We have a data mart that researchers can access. It does not contain identifying information. That identifying information is held by honest brokers at each of our health system partner sites. So patients can be re-identified with human subjects approval to be contacted to participate in research studies, as well as we can provide data sets to researchers with limited information in it. We call it a HIPAA limited data set. So the patients are not identified, but there is information in there like dates and things like that. We also use some of our advanced computing capabilities. Everything at the University of Florida is called Gator, which is our mascot. So we have a HyperGator AI computing system that we use to store and manage all these data. And the data do undergo quality checks very rigorously at both the local and the national level. So I will stop there and look forward to questions and discussion.
Any mention of the word gator always brings me out in a nasty, nasty rash. I've been to Florida and I've seen far too many gators to sit comfortably with that one. So whilst I've got your attention, Betsy, let's move on to the next session, because I think for us, we've now had I think 4 really unique case studies there, from Africa, from Europe, from the US, and from Latin America and Chile as well. But I think from you, what do you think? Because you talked about the connections you've got there with other states. What are the opportunities that are there for you, Betsy, in terms of data sharing across border, into other states? And then what are some of the barriers do you see?
Well, certainly I think that there are huge opportunities to share. Obviously, we worked out the data sharing quite well within the United States. And what I'd like to do is be able to explore with colleagues, what are the opportunities using these privacy preserving linkage mechanisms to be able to share data that, again, in the United States terms, what we call HIPAA limited data sets. Again, they have some dates, they have some information, but you're not getting patient exact names, you're not getting addresses. And I would love to think about a data linkage pilot that we could think about to be able to share and understand data, because I think there's so much to learn from each other.
Okay, well, I'm immediately half the audience who are interested in projects, or their ears have suddenly pricked up and they thought, oh, projects, that sounds fun. What are some of the barriers, do you think, Betsy? Do you think?
Well, I think that certainly whenever you go out of the boundaries of any individual country, certainly we face, additional scrutiny about the country. So I will put that out there. So that would be something that we would need to be careful of and think about. And we do have mechanisms to do that and work with that. The other thing is all of our partners are giving us their electronic health record data. And so we have a shared governance model. We'd need to work with our partners to see who would be comfortable with the concept of perhaps sharing data sets to learn about particular issues. And what we learn with our partners is it has to be a topic they care about. It could be maternal health. It could be child health in a certain way. Those would be things that we would need to understand. Are there topics where we have shared common interests, and then work with our partners to say, yes, we could share data. So some of these I don't necessarily see as barriers. I just see them as challenges to address.
Okay, that's helpful. Opportunities and barriers. What do you think, Maya from Chile? What are some of the opportunities that you think are there from your side to share data out of Chile across the rest of Latin America, but also maybe with Betsy in Florida and Sarah and Felix, say, in Africa? And what are some of the barriers?
Yeah, of course. Well, one of the main issues we have in Latin America is that most of the research that's done worldwide, it's not population-centered or not using the genetic backgrounds that are present in Latin America, which is also very diverse. So for us, the main advantage of sharing data across borders would be to be able to generate larger data sets that are genetically segregated and would allow us to make more adjusted analysis of these populations. I think that would be certainly the main benefit for us. And it would also enable us to better provide healthcare to all the migrant population, because we have we're increasingly becoming more interconnected as a continent.
And what are some of the barriers, do you think? Other than, because you talk,
yeah,
is it Is it people who say no in great big offices, or is it ethics committees, or is it cash?
I think the main barriers right now would be the the different regulatory frameworks of each country, and also the digital maturity levels that there's a lot of disparity among Latin American countries.
Okay, that's helpful to understand.
So yeah, we should be working on that. There's this network called Raxel here that's tackling that issue, and it's mainly a group of 15 health ministries across Latin America that's working on that.
Okay, that's helpful to understand. I think it's a problem, certainly, and I'll come to you now, Sarah from Portugal. That's not an unknown issue across Europe, because there's differences in terms of where different countries are at in Europe. But Sarah, what do you think in terms of what are some of the opportunities, and then some of the barriers do you think that are there from your experience?
Yeah, I also agree and believe that that data sharing across borders have so many advantage in terms of primary and secondary data use. So the data, like I said in the previous question, the data of the patients enables better healthcare providers. When healthcare providers have access to their data, can provide a better care service, and also for research activities to accelerate diagnostics, treatments, and clinical findings by using data as evidence. So as there are many opportunities, I think there are many challenges or many barriers that are difficult and impair the data sharing. And I think that interoperability and technical requirements are one of them. So the capacity of health systems to communicate between them and under the proper conditions of security, privacy, and data quality, I think it is very important and a huge difficulty for data sharing. Also, I think that literacy and awareness is a great, very important area to improve for enable data sharing. So all the stakeholders involved in the process of data sharing, including healthcare providers, citizens, researchers, industry, companies, all of them need to be involved and need to be aware for the potential of digital health and health data, and should be aware for the use of data and how data can be used. And I also agree that regulatory is an important need to overcome. So important to harmonize the regulatory landscapes. So
Okay, that's helpful. I think a very, very clear but very, very wide understanding there. I've got a couple of questions coming in from our audience, but first I'm really keen, because Felix, what are some of the opportunities there for you, do you think, around data sharing? Because you've obviously got a very well structured series of data management there in Tanzania. What are some of the opportunities? Where are some of the barriers? And then we'll come to some questions. Felix.
So thank you very much, Andy. And I think most of what my colleagues indicated as opportunities and challenges apply also into our context. And we need to bear in mind that when you talk of Africa, we have different contexts within one country and the other. And as I indicated, we need to, when you are thinking of data sharing, we need to know the ecosystem where data is being generated and maintained before you share. You need to collect. So if you look at the WHO framework around e-health planning, you have infrastructure and standards. So we need to have that from the design point, the infrastructure that supports data collection and sharing within one country, but also across, especially at the lower level, the rural settings, infrastructure is not mature enough to support this, because most of the systems will be in a siloed structure within one facility. And they are not, if they are not interconnected, that will be a challenge. But areas where fiber connectivity has reached in the regional level, at the county levels, we have the backbone, so people can share data. But then do we have systems that are enterprise-based and standard-based? So those are enablers. But the workforce aspects or people-related aspect in terms of knowledge, skills, and attitude around sharing. Some people may not trust sharing data between one facility and the other, but also within one country and the other. Not necessarily that legal and regulatory framework is inhibiting them, but the trust around why should I share?
Right.
What will be. So for researchers, it's easier for them to share data because they have a quick win around publication, innovation, and likes. But for service delivery, we need to share. During surveillance, data is one of the areas where people share data. But in some cases, people don't share data because when you share, the system penalizes you for sharing because you may get effect in terms of tourism and the other aspects. So at Africa CDC level, you have these frameworks that are being developed. So we need to have policy makers on board to ensure we have right legal and regulatory policies, and also invest in the infrastructure and capabilities or skills sets that is needed.
Excellent. Just whilst I've got you there, Felix, one of the things, obviously, we've seen there's a European-wide approach that Sarah's talked about. Maya's talked about the approach across Latin American countries, and Betsy's talked about some of the cross-state work. In terms of, say, Africa, what are some of the pan-African approaches on this, just briefly?
So thank you very much. So if you look at the African Union, they have data policy, which is promoting data sharing, and it's general, it's not health specific. But if you come into the health sector, there's a flagship digital health transformation strategy under Africa CDC, which is more of a flagship around digital health and data. And there is a health information exchange guideline that promotes member states to share data. If you look at the regional blocks, you have regional economics blocks like IGAD, East African Community. East African Community has developed data governance framework, and the bigger component is how do you ensure that partner states or member states share data in an ethical, responsible manner. And we involve, for example, during the development, members of parliament as key stakeholders. And when they see value of why they need to share in terms of disease surveillance, prevention, in terms of cross-border health information exchange, because people are accessing services in different partner states. They need to ensure they traveled with their health information. So there you see the values. And you have noted some facilities which have branches in these partner states. They have a platform where they share data. So those are experiences, especially for the private sector. And we have the data sharing agreements that are already in place, and the policies, most of the countries have the policies for personal data protection with cross-border data sharing clauses where people need to apply and they need to sign data sharing agreement as long as it's within the benefits of the country sharing, but also the one requesting.
Okay. So that's I think political buy-in is important. And I don't think I've been to a country where that's usually, or except for a few where the government's not been elected. But I've not been to many countries where the political buy-in is not needed. So I think that's a useful tool there. I'm just conscious we've got a couple of questions zipping in from our audience, and we're keen to get more questions. If you've got any questions, stick them in the Q&A session at the bottom, which and then we'll get through as many as we can in the time we've got available. But certainly, as soon as we've got all these experts here from around the globe, let's go. One of the first questions I had, and I'll come to you, Betsy, first. And this is the one that makes me a little bit grumpy as an individual. Where are patients up to in this? Are they willing to share data for both primary use and secondary use, or are we assuming stuff? What's the mood music coming from Florida on this?
Yeah, that's a great question. So thank you, Andy. The Patient-Centered Outcomes Research Institute, which is the primary funder for One Florida and the other 7 networks, have a steering committee that's 50% researchers, 50% patients. Also within One Florida, we do have a shared governance model with patient representatives on our executive committee. So patients are there every step of the way. In terms of our human subjects and regulatory approval processes, because these data are stored as with only certain information available in terms of dates and things like that, we do not need patient permission to aggregate and store these data, update them, and link them. So when the patient permission comes in is if the honest brokers re-identify the patients, and we work with the clinical settings for them to reach out and contact the patients, and then patient approval would be needed for them to participate in an interventional research study. Now, if we provide a HIPAA-limited data set, we do not need patient permission. So all that has been worked out in terms of the regulatory components.
Okay, that's helpful. What's the picture like in Portugal, Sarah?
Yeah, in Portugal, the primary use is more frequent than secondary use. So, and it is easier to sharing data for primary use than secondary use, because there is a national infrastructure that enables data for use, and there is no national infrastructure for secondary use. And also the regulatory framework is better established for primary use than secondary, that in secondary data use, Portugal follows the GDPR and have others local laws and regulatory framework, but not at national level.
Okay, okay, that's interesting. Slightly different approach. What's happening in Chile, Maya?
Sorry, I think here in Chile, it's something similar to what Sarah was saying. Most of the conversation is revolving around the primary use of data, but I think we need to also pay attention as a country and as a region to all the benefits that the secondary use of data involve. Like Felix was mentioned, we need to look deeply into the people aspect of these things. There's a lot of reskilling that needs to be done in Latin America in order for us to be able to share data among us and eventually across continents. So since it's been up to the task and has released the digital health skills framework that aims to identify the skills required to perform efficiently across different domains, and looking into 4 different profiles. First, for the decision makers that need to be up to the task and aware of all the nuances of data sharing, for IT professionals, for health professionals, but also for patients. I think that patient literacy here is paramount.
Yeah.
And they need to acquire new skills to take advantage first of a new digitalized and interconnected health system, but also to understand the benefits of sharing their personal data in order to build knowledge.
Okay. So I get that. And I'll come back to you in a sec, because I want to talk about health inequities and inequalities as well in a moment. But Felix, from your side, with patients there, what's the level of interest in this? You know, are people more interested in their sort of primary user data than secondary, or what's it like there in Tanzania?
So thank you very much. So one aspect is all depends on the level of exposure or knowledge someone has in terms of the use of personal information. One, and also who is collecting. So the small trust on healthcare providers for an individual or clients, patients to provide data to healthcare providers, because they need. We have, if you are doing it for research, then the ethical approval that you need to get from the research councils gives the mandate for the patient to give consent. And in most cases, these are descriptive enough to inform the patient or the client or data subject on the benefits, and also if there's any risk around that. And people have that trust with the systems that are in place in terms of providing the data. So one is they will expect data will be used for patient care, but when it's research-based, then they will provide. But some people at the community level, we had experience, I think Zanzibar in here, it all depends, as we said, on who is collecting. If they know it's community healthcare providing the data, is like, this is someone we are with him. So you need to educate the community leaders and the respected people, depending on the context, in ensuring that whoever is collecting data it's within the national policy frameworks, but also they need to put trust on. And that's where we also need the political decision makers to really advocate around providing quality data, but making sure that there is ethical system that people can trust in providing their data, but around also secondary use.
Okay.
Some of the iniquities will be in the private sector. They are not, the investment in digital health and data system is huge. So you need to ensure you have the resources to do the investment. Otherwise, some people's data may not benefit the research and innovation, and that's missing some gaps around. So as we work on data sharing ecosystem, we need to ensure we get data that are required to make a decision from all the angles, and the aspect to do with access to internet connectivity whenever you're collecting data through digital platforms or online platforms, then you may enter missing some data that are necessary to inform decision making. Yeah,
I see. Now then, you've fallen for my trap, which is the following, because you mentioned, a couple of you mentioned the word trust, and a couple of you mentioned the word, and we talked about health inequalities. How do you think, and we've only got, I think, just north of 10 minutes for this. How can we use data, okay, to start tackling some of these health inequalities and health inequities in different countries? So that's number one. And then I'll come back to you on the trust piece. So just quick fire. Sarah, how are we going to use data to start tackling health inequalities? And then I'll come back to you, Betsy. Sarah.
Yeah, I think I need to talk about the primary and secondary use, because I think it is important to enable this data sharing for all citizens. So trying not to exclude some regions or some groups of peoples because the age or the gender. So and the data have the potential to include all citizens and not discriminate. And I can talk specifically about the data sharing across Europe and focus on the European Health Data Space, because the European Health Data Space aims to reinforce the primary and secondary data use, and they have this baseline objective of including all citizens. So try to reduce the difference between eventual groups or eventual difference between people or between countries. So and I can link also to the other project. There is a European project that result of a consortium of 4 health clusters and innovation networks, and the health cluster Portugal was involved in this project that ended on September of this year. And within this project, in particular, Health Cluster Portugal was responsible to develop a joint action plan with actions and activities for all member states of European Union, so European countries, to implement or advance the European Health Data Space. And for developing and constructing this action framework, the first step was to identify the many challenges associated with the European Health Data Space implementation. And for this, it was important to analyze different countries, and it is possible to understand that the European countries have different maturity levels, and some countries are more or less advanced. And if these differences are visible in Europe, so these differences are still more visible at a global scale. But the objective should be try to facilitate the data with this difference and with the particular needs that each country have, because countries have different weakness and different strengths, and each countries need to access these their needs and try to overcome and address these shortcomings that each country have. And I think it is the unique solution or the unique way to try to enable a data sharing across Europe and across a global data sharing that include health citizens and health stakeholders of the health ecosystem.
Well, it's clear to see why Portugal have been leading projects like this with such expertise. And if you want, if you've got the link for some of those projects, we'll share those with participants afterwards, because I think it's important, because you've been involved with many of these projects and it's clear to see why. Whilst I've got you, Sarah, what are we going to do about trust in healthcare data? Because for a lot of people, trust is a missing, they lack trust in their government, or they lack trust in their government data. How do you think, within Portugal, how are they looking to help build that level of trust? And then after, I'm going to come to Betsy, because I want to hear a US perspective. But from Portugal first, Sarah, how are we going to rebuild and build more trust in the use of healthcare data?
Yeah, I agree that literacy awareness and public trust is an important dimension for enable data sharing, and in this case for implementing the European health data space. And for instance, in citizens, I think it's easier to have trust and citizens be more aware for primary data use than secondary data use, because I think that the benefits and advantage of the primary data use are more evident and easier to understand than the secondary the advantage of the secondary data use, because it is more difficult to understand the research activities or the innovation activities that can be a result of data use. But I think that is very important to reinforce education for the potential of digital health and health data. Countries need to promote more educational plans for all the stakeholders involved. For instance, training for healthcare providers, be aware about how they can share and use the data of their patients. Citizens need to know how their data will be used. Research need to know how can use data with the proper conditions of protection and privacy. So I think that trust and awareness is a very important dimension for enable data sharing.
Wonderful, wonderful. Betsy, over to you.
Yeah, thank you. So in terms of health equity and disparities, I think as many know, we have those are significant issues in the United States. So we do have information, and the network was particularly designed to ensure that we had racial, ethnic, geographic diversity in terms of urban and rural settings, as well as socioeconomic diversity. So that information is available in our data about the patients. And, we do, of course, misinformation such as, immigration status or primary language spoken in the home. That's not always available, and those are important variables. But we do have information that we could share, and it'd be very important, I think, to look globally about the health outcomes that we're seeing by some of these different characteristics. In terms of building trust, I think the way One Florida Plus and the larger network called PCORnet was constructed, we all have community engagement programs, and we all have patient stakeholders that are part of our networks. And so we actively work in community settings to talk about the research that we're doing, to talk about the data, how we're using it. And we have a variety of online and interactive resources that we share with community members to keep them engaged. The other thing that we do is we also make sure that patients are part of every single study that we do, so that they have the opportunity to speak to their peers and say, hey, I'm engaged in this study, and here's been my experiences, and here's how they've used the data. We think that kind of peer and community interaction is really important.
Exactly. Maya, I'm speeding things up because we're getting close to time. Maya, in Chile, how do you build that trust? And you're on mute.
Sorry. Well, for trust, I think it's mainly what I said before. I think it's health literacy, trying to engage in cooperation and not stand there alone trying to build trust, but do it as a group of articulated actors. I think that's key.
Excellent. That's short and to the point. The last word on this, please, from Africa. How is this approached in Africa? Is it something where you think you've actually got, are you in control of this now, or less so, do you think? Felix?
Thank you very much. I think trust building is a stakeholders engagement component or community engagement and building into the existing ecosystem, not only in the health sector, but the community as part. So there are trust systems that are within different communities in Africa. So how do you use community leaders? How do you use chiefs? How do you use the existing governing structure to ensure that stakeholders are engaged in terms of we are do mapping, you are understand the needs, and also define the priorities and benefits that everyone is going to reap in the data ecosystem and data sharing ecosystem. And at the end also communication, proper communication to different stakeholders in terms of what we want to do, be it research, be it intervention that we want to address, to ensure that everybody has an understanding, and that's part of the literacy, data literacy and health literacy, but also making sure the ecosystem is well informed.
Well, there you have it. So we've heard, I think, from across the globe today, a lovely, different, diverse picture. Have we got issues around regulatory frameworks? Of course we do. Does anybody here have a moral right to claim ownership of trust as an issue? Of course not. And it's important, I see with Sarah, who's given really clear ideas of how people can move between the use of primary and secondary data in one country and across a continent. It's a fantastic opportunity, and I think one which I want to come back to another time, because that global input is what makes the Global Health Connector piece work, because we cannot carry on trying to reinvent the wheel. There's so many issues here where we've cross-pollinated thought, and I know Felix and Betsy and Maya and Sarah, many of our audience will be wanting to get in touch with you and find out more about One Florida, about SENS, about Tanzania, and also about Health Cluster Portugal. Thank you very much from me, and thank you for your input. We're going to finish ahead of schedule. Thank you very much.